Great. Thanks, John and Bill. So I thought I'd just quickly give a personal perspective on, after doing the NICE guidelines for 2 years, what it was that they were trying to achieve. I think right at the beginning it became clear that NICE felt that there was quite a lot of evidence of variations in practice, which John has already very clearly demonstrated, evidence of suboptimal practice. And so I think the aim was to reduce the variations in practice that there are in bladder cancer and to raise the standards. So it should perhaps be seen not so much as a gold standard of what you should be doing at the cutting edge of bladder cancer, as really just a manual of how you should have a bladder cancer service in every hospital in the NHS. So to move straight onto the guidelines, what I've done is to put all the recommendations for non-muscle invasive bladder cancer in, but then just highlighted the ones in red that are important. So really one of the first recommendations, 1.2.3, is the fact that when we reviewed the evidence, anything that you used in addition to white light cystoscopy gave better results than white light alone. But we couldn't really distinguish as to which one of these additional aids, such as photodynamic diagnosis or one of the biomarkers, was better than the others, because obviously there are no comparative trials. So we just felt that you should use something in addition to white light rather than white light on its own. And really the simplest one to use I've highlighted there, which is urine cytology. So at its very simplest level, all the recommendation is saying is to use cytology perhaps in addition to white light, and you can see with carcinoma in situ why that would be relevant. Then right at the bottom, there is the recommendation to give a single dose of intravesical mitomycin at the same time as TURBT, and John really illustrated that a number of patients, even in the setting of a clinical trial with enthusiasts, are not getting it. And the important word is at the same time as TURBT. It was very clear that what we meant was to give the mitomycin in theatre. And this is a technique that's been in use since 2001. There are quite a number of hospitals that are using it. And in that time, there have been no serious problems with giving it at the time of TURBT. So moving on, perhaps the most practical recommendation for every MDT is that every patient should be put into a risk category. Obviously that's low, intermediate and high risk, so that should be defined at the time of the MDT so that it follows them throughout their diagnosis. And then if you separate all the patients into their intermediate risk category, their management will very much depend on which risk category they're on. Specifically with intermediate risk, John put up a slide showing that this is one particular area where patients seem to be receiving suboptimal treatment, in that many patients aren't getting any kind of intravesical therapy at all. So there is a clear recommendation that patients in intermediate risk group should be getting 6 doses of intravesical mitomycin. Moving on to high-risk patients, again, perhaps something that's not a surprise to centres of excellence, but patients should be offered the choice of intravesical BCG or radical cystectomy. I should add that the guidelines were being developed before we really had this second BCG shortage, so ironically, probably the issue of giving radical cystectomy has come very much to the fore now, but certainly there was a feeling that the 2 treatments should be offered to patients who are suitable with equal weight. And then one specific area which has become increasingly topical is what to do with patients who failed BCG. And really the recommendation was that they should be referred straight away to the local or regional specialist bladder cancer MDT. So in other words, if a patient fails BCG, you shouldn't carry on managing them locally. They should be referred to a specialist center to decide whether they're fit for cystectomy or further intravesical therapy. And then probably the most, arguably the most controversial recommendation is this one, which was actually based on economic modeling and analysis, which was that patients with low-risk non-muscle invasive bladder cancer, assuming they hadn't had any recurrences in the first 12 months, they could be discharged back to the GP. And in fact, there's quite a specific recommendation is that they shouldn't be followed up beyond 12 months. And hopefully we can have a discussion about what people feel about that. And then intermediate risk, essentially, we've said that the patients could be discharged after 5 years, so you could almost think of it as the surveillance have all dropped down one category. So now we're suggesting that patients with intermediate risk should be managed in the same way that up to now patients with low risk have, and be discharged after 5 years. And then finally, high-risk patients should just continue once they have passed the initial stage, once a year indefinitely. So there's no change in the follow-up for high-risk patients. That's it.
Hugh, thank you very much. We will take questions at the end.